It says stop my video. I'm not having a video, but it doesn't. I prepared. Wow. And then part I would like to talk about the mass vaccination a little bit. So today we are at 272,374 individuals that have tested in Douglas County. Close to 50% of the people have tested once. We have 47,197 cases, and we have 23,755 who have recovered. Our 7-day rolling average as of last night is 72.4 new cases per 100,000. It's nice. It is starting to go under 100. I was really concerned when it was over 100 new cases per day per 100,000. Our positivity rate last week was 28.3%, and that was by report date, and it has been down. It was up to 33% the week before. So we see positivity has gone down. Also, our highest confirmed cases were the week of November 7th. And since then, for 5 weeks now, we have seen a decrease in our cases. Now, I want to share with you, we have had some issues with laboratory reporting because what has happened is some of the laboratories are keeping their tests and are reporting them all in one chunk. So, for example, we have received a number of, this comes from the state. They need to report to the state then reports to us. So, last week we got 250 cases on one day from one laboratory, but the cases went back to November 15th. Which is an issue for public health in the first place because that means we cannot do contact tracing in a timely fashion. The individuals get informed by the laboratory if they are positive, so hopefully those individuals will be isolated. But still, it's not the right way. We have worked with the state very hard over the last 2 weeks with each of these laboratories. We have a lot of laboratories who are reporting, and nowadays they are coming, new ones are coming on all the time. They are not aware what the reporting requirement is, and it's not working very fluent at this time. It's getting better every day, but still. So that's why really when you look at the confirmed cases on when they went and got tested, that's a better indication than when they were reported to us. When we look at race and ethnicity in our white population, 46%, black 7%, a really an amazing number how the African American community positive cases are low in our community. I'm not quite sure what it is. I talked to Kenny about it at Charles True. They are seeing some of the same things. Hispanics, the total from the beginning up to now, it's 19%. Asians make up 4% of the positive cases. Native American, 0.7%. When we look at the age ranges, we still see that the highest age range is in the 20 to 34-year-olds, namely 31%. Then the next age group is 35 to 44 years old. At this time, when we look at hospitalization, hospitalization is probably one of the best indicators because either you are so sick that you need to go to the hospital or not. So when we look at our hospitalizations, and you can look at it nice graph on page 3 on the bottom. It really shows you how our hospital rate is, how our COVID patients in hospitals are down from a high of 433 on 11/22, and it's now 362. So 433 to 362. 45 patients, the lower line are the ventilators. 45 patients are on ventilators at this time. And as you can see, that has been staying kind of consistent. 45 people on the ventilator is a lot of people on the ventilators, because once they are on ventilators, they stay on there for a longer period of time. They are seriously ill, and healthcare providers will tell us at least 50% of those individuals are not surviving. So the next graph on top, you see death, a death per week. And, it's hard to talk about just in numbers when you talk about death. I have to tell you, it's heartbreaking. Every death certificate I look at, I choke up a little bit. And what you are seeing there, you are seeing these 3 weeks when we were really high. On 11/14, we had 35 deaths. The week of 11/21, we had also 35 deaths. And the week of 11/28, we had 32. Those 3 weeks together. And if you look at the first week in November, we had 127 deaths. That's out of a total of 405. It is the highest month of death we have seen in Douglas County. In December so far, we are at 21, but as you can imagine, that always death certificates come in late, and so that number, I'm sure, is going to change. On the bottom there, you see the age ranges, the ages of the individuals who unfortunately died from in assistance for COVID in our area. 71% are white, 12.3% are black, Hispanics are 13.6%. That's actually on the next slide there. But you again see on the bottom slide, the ages are higher rates, and potentially 80% are above 65 years and older. The only other thing that you have on page 5 in the lower graph is the underlying conditions that are on the death certificates of these individuals. What is interesting is the last point there. It shows how many individuals did not have any underlying condition, meaning only COVID-19 was on their death certificate, and that number is increasing. It used to be 11% for many, many months, and it's now up to 15%. So that's kind of the data. In summary, cases are decreasing, hospitalizations seem to be decreasing, deaths are lagging behind, and so potentially we may see further higher cases of death over the next 2-3 weeks. So let's talk a little bit about vaccines, because I think there is so much good news around vaccines. So the first slide there, I'm just showing you some of the phases. Just overall general knowledge. There are these phases that these vaccine trials have to go through. The first one, really phase 1, looking at safety and having a very small volunteer pool that participates in those to really try to determine, is there anything that researchers need to look out for. And then phase 2, you have a larger group of volunteers there that have to be enrolled in these trials. And phase 3 is where you have these big trials. Phase 3 are the big trials where you bring thousands of individuals together. And then phase 4, of course, is where you show your data and you get into an approval phase. So what we have heard from the two vaccines, Moderna and Pfizer vaccines, that they are messenger RNA vaccines, and people often ask, so what does that mean, and so on. And so there are a few bullets there. They carry some genetic material that teaches our cells how to make a harmless piece of the spike protein. The genetic material of the vaccine is destroyed by our cells once copies. Cells display the piece of the spike protein on their surface, and they then create their antibodies. They do not affect DNA. I can't tell you how many questions we are getting. Is this affecting our genetic material? These vaccines, mRNA, they do not enter the nucleus of the cells. I think that's important. Also, these vaccines, they cannot give you COVID-19, and they use technology that is new, and often people say, well, it's new, it hasn't been used before. This technology has been researched for 10 and more years. So it's not new technology. We have invested, the federal government has invested in these new vaccines. On the next slide, I thought just for you specifically, and also for the community, I want to point out who was involved in these trials, because that's really looking behind. I can tell you, I spent this weekend, about many hours looking over the data, looking at what the recommendations were from the information team that the FDA then provided recommendation to the FDA. So I always want to see it with my own eyes. So I thought you may be interested in too. So you see the two vaccines, the Pfizer and the Moderna. The Pfizer has 43,000 individuals who are involved. The Moderna has 30,000 individuals who are involved. Then you see the different clinic sites. This is not one site, but these individuals are through the world, actually. You see they have 150 clinical sites for the Pfizer vaccine and 89 for the Moderna vaccine. What is interesting is the race ethnicity breakdown, and you see there in the Pfizer trial, 13% of the trial participants were Hispanic, 10% were African Americans, 6% were Asian, and 1% was Native American. 45% were in the age range of 56 to 85. When you look at the Moderna vaccine, 20% are Hispanic, 10% are African American, the same amount as we have in the Pfizer vaccine. 4% are Asians, and 3% are all others, which are Native Americans, Hawaiians, and so on. And 64% are ages 45 and older. 39% are 45 to 64, and 25% are above 65. So then you hear, well, this is warp speed, and this went ahead so quickly. What have we sacrificed by going this speed? And it is really important that we communicate clearly about it. First of all, these were existing clinical trial networks that we have used. So these sites that participated in these trials, they were sites that have been established, that people had known about it. What is interesting is, and we only could do this with support from the federal government, is the manufacturing of these vaccines started at the same time the trial started. That doesn't happen usually. This parallel working, that's what sped up everything. Usually what you have phase 1, 2, 3, and 4, and then if everything works, you go into manufacturing. But here, everybody took a risk and started to manufacture in phase 1 already so that they would be ready if their vaccine would be approved. A little bit a risk. What if the vaccine wouldn't have worked? all that manufacturing would have been for nothing. But that is one of the major reasons why this was done so quickly. Also, we know that the messenger RNAs are easier to produce than how we usually produce the flu vaccine. That takes quite a bit longer. And FDA and CDC are prioritizing their review. So on the next slide, slide 15, you just see shortly what the Pfizer vaccine is. It has a dose regimen of 30 microgram. It has 2 doses that are 21 days apart, and it comes in 5-dose vials. So in a small vial, there are 5 doses in there. And it needs this ultra cold storage. And once you take it out, you can actually keep it out for 5 days and use it up. The bottom graph, it's interesting. I saw somebody use this also on the news this morning because I thought when I looked at the data, this was so telling. This is a graph that shows the cumulative incidence of COVID after dose 1. So what you are seeing is you are seeing 2 groups, the placebo group and the group that received the vaccine. Placebo is the red line, and the vaccine group is the blue line. Up to about day 10, they are the same. But what you are seeing in day 10 to 14, these 2 lines are going in different direction, meaning the placebos, they are still getting COVID-19. They are still being infected, and that's why that line goes up red. However, those that receive the vaccine, it stays stagnant. We have hardly any new cases. That is after 1 dose. That shows you how effective this vaccine really is. On the next slide, the next question is, so we know we have good efficacy. What about safety? That's really the next question that everybody asks. So there are expectations. We knew that from the beginning that these vaccines are going to have certain adverse effects. I wouldn't even call them, or you could call them side effects: fever, headache, muscle aches. But no significant safety concerns were identified during the clinical trial. We have heard since then, 2 individuals in Britain had anaphylactic shock after they got the vaccine. And so researchers are really looking into this. Why is this? And the bottom graph, 18 on slide 18, it shows you what those effects were after dose 1 and the bottom after dose 2. So you can see there pain at injection site. You can see the 30 microgram, that's the individuals who received the dose. 83% were experiencing pain at injection site. You can see they have divided it up by age ranges. The first is 16 to 55 years of age, and the second one is above 55 years of age. Again, what is interesting, what you are seeing there, is that potentially the younger ones, 16 to 55, had a little bit a higher pain incident than the one 55 years and above. And you see that also on the next slide. The next slide just continues on what are some of the other adverse side effects that you see. The most pronounced, probably fatigue. You see 59% of the 16 to 55 years old had fatigue. And you see headache, 51%, 35% had chills, 37% had muscle pain, and 21 or 22% had joint pain. Very normal reaction. It's your body reacting to the vaccine, making an immune response. It's actually good that you have these reactions. What I thought is striking is the bottom graph. It really shows you everything together in a timeline. It shows you that these effects are mainly on day two after you have been vaccinated. And by day three, they are disappearing and it goes further down. And by day seven, you hardly see any side effects. So day two is really the one where individuals just should be prepared for, yes, we are experiencing some side effects, but if I wait 24 more hours, they should be gone by that time. What are we doing to really try to learn more about safety? And let's say if I have the vaccine and I have some side effects, how do I report this? So there are older systems that we have with flu at this time. It is called the VAER system, Vaccine Adverse Event Reporting System. That is a central system that CDC uses for reporting nationwide when there are side effects. So they take that all into account. They then follow up with those patients and so on. So all the top ones, the four, are systems that we have in use at this time and have developed. There is a new system, it's called vSafe, that is being used with this vaccination too. It's kind of like an app. You register for it when you go and get vaccinated. And what it does, it then follows you for 14 days and sends you texts every day and asks how you are feeling. So that really we can determine, are there, because now you are doing much more than 40,000 participants. You are vaccinating a large population. You really want to know, are there some things that we potentially missed in the trials? And so those systems are being put in place at this time. And I think it is really beneficial. I tell you, the development and the evaluation of these vaccines have been so transparent. We have never seen that we could participate and see the data from these manufacturers as we see from Pfizer and from Moderna now. Never has that happened. Never have you had the ability to follow by Zoom these 22 individuals who are going to vote and making recommendation to FDA if you should approve this for emergency use authorization. So I think, it couldn't have gone really any better. The efficacy you heard, we all know now, Pfizer 95%, Moderna 94.5%. And this morning, I tell you, I even got a bigger smile on my face when you heard the early data from Moderna, even after the first dose, showed that potentially the transmission of the virus is decreased in the individuals who received the vaccine. This is the thing that we didn't know from Pfizer, and it was a little bit disappointing that they didn't study it, and therefore we said, everybody needs to still wear masks because we do not know, can we be asymptomatic and still transmit the virus. But this morning, some of the data that Moderna is bringing out is showing that the transmission is decreasing by quite a bit. So now, we are getting into implementation, of course, and that will be the next step. And our department is feverishly working on this and doing the logistics about it. As you have heard, the first number of vaccines have arrived in Douglas County. In the state of Nebraska, the entire state got around 15,600 doses. And that went to 8 health systems. And it went to those 8 health systems because those systems had the cold storage and they could use a large amount of the vaccine once they opened one of these boxes. So, but a smaller portion of these vaccines are going to be for emergency EMS staff right now, and we are working out the logistics as we speak to see how that is going to go. So in phase 1A, highest priority is EMS, emergency department staff, all those healthcare workers who really deal with COVID patients. not the healthcare workers who are working in dermatology offices or some other office, really those who treat COVID patients. And the second component is persons who live in long-term care facilities and healthcare workers in long-term care facilities, because we know what the effect of COVID is on the elderly population, so it only makes sense that those are the first ones to get vaccinated to decrease, hopefully, at very severe health outcomes and death. But what is happening with long-term care and long-term care health care providers is they actually were able to enroll in a pharmacy program that the government put together with CVS, Walgreens, and some community pharmacies. And so those pharmacies will go to those long-term care facilities and vaccinate those individuals. So that is a large proportion. Just to give you a little bit of number, the governor talked yesterday. In this 1A group, healthcare providers make up 90,000 individuals in Nebraska. Long-term care residents and healthcare providers in long-term care make up 50,000. So that's 140,000. We expect by the end of December to have potentially 100,000 doses. So you see, we can't even really vaccinate all of these individuals. So it goes from week to week. And one of my staff says, I think, the biggest word is patience at this time. We know the vaccine is coming. We know we are going to be able to provide it, and people should have access to it, but it will come in phases. And people some of the individuals will have to wait a little bit longer. But, at least I said to somebody yesterday, this is like, it's really very appropriate that this happened in the holiday season. We are celebrating Hanukkah, Christmas. What are we celebrating it? We are celebrating it with lights. And vaccines have suddenly become a light now in this really pretty dark last 8-9 months. So I'm thankful. Also, there is hope. I think those two words we cannot underestimate. And I just can tell you, for me, this weekend and these 2 days have really been great days, because we are seeing what science can do. And we really should applaud all the scientists who are working on this every day behind the scene to give us these vaccines that really can prevent bad outcomes. So with that, I'm glad to open up some questions.
Before you get off that topic, let me read, because this might be this is a question for later that I can get out the way now. So on Carrie's report, and it says number 5, mass vaccines, it says, federal pharmacy program, the Nebraska DHHS signed up for this program, which provides opportunity for long-term care facilities to voluntarily sign up and identify a primary and secondary retail pharmacy chain, i.e. CVS, Walgreens, etc., to provide COVID-19 vaccines to both staff and residents. Douglas County Health Department is still watching for the final list of long-term care centers that have signed up for this program, but we anticipate approximately 12 have opted out of the program.
Say that again a little bit louder.
It says the Douglas County Health Department is still waiting for the final list of long-term care centers that have signed up for this program, but we anticipate approximately 12 have opted out of the program.
That is true. We do have the list. We know who has opted in and who their partner is. And then there are some who somehow may not have matched right, or may have decided they didn't want to enroll. And so to those, we will reach out and try to see, do we need to vaccinate their facility? So that's what we will be doing.
Okay, so you don't know yet if this, because when I read this, I'm like, why would you opt out?
No, we know who those. I looked at the list last night. Yeah, we know exactly who those facilities are.
Is there some reason so you think it's a discrepancy? There's not some
Yes.
reason why they would opt out of this?
Well, if they opted out, meaning they do not want to vaccinate, that's a different story. But
Yeah,
I
that's what I
don't
mean.
think
You don't
that's
know
the
that.
story.
You don't know that.
We don't know if they
Okay.
opted out completely.
Okay.
I would be very surprised.
Okay.
Any other questions?
A couple of things I'd like to say. Dr. Poor, first of all, thank you for the presentation. And, you know, what I wanted to say, this is just a comment. This is the second time I've heard this presentation, believe it or not.
Oh,
The
yeah.
first time I heard this presentation was on 60 Minutes.
Oh.
and then there was a portion of it that was on Nightline on Monday night. And one of the things that I was not aware of, and I would encourage people, if you have a streaming service or whatever, that you stream the 60 Minute show from last week, or that you stream the Nightline show from Monday night. Because in that, there are a couple of things that I think are, that I think we need to utilize. First of all, I was not aware until I watched the 60 Minute show that the researchers went into, they realized this prior to Wuhan, China. I didn't know that. And I didn't know that they had started working then. That came out in the 60 Minutes story. The other thing that came out in the 60 Minutes story was who the lead researcher was. And when I found out that the lead researcher was an African-American woman, I think people are going to start to say, well, because for me, I'm going to invent a slogan, if you would. I'm betting on the sister. So, but I think it would be beneficial for people to look at those, because a lot of this I had seen already, but they had presented it on 60 Minutes. And I wasn't aware how long the researchers had started going to work on these vaccines. It happened prior to this year, back in November, I think it was. So I appreciate this because it not only does it verify what I was watching on the two news shows, but it also gives us ammunition for when we're talking about whether or not you should receive the vaccine. So thank you for that. That was just a comment that I just wanted to share with you and the board.
I think that's
Thank you,
important.
Mr. Chair.
Thank you.
Good morning, Dr. Ali. I have a couple of questions. In regards to the vaccine, guidelines and restrictions for the vaccine, age restrictions, previous medical histories, previous positive test findings, pregnancies, and breastfeeding. Is there restrictions or guidelines recommended for those people that qualified in that list?
Okay. So the first one was about age. So the Pfizer vaccine is for 16 years and above. The Moderna is for 18 years and above. So there are clinical trials that have to occur with children. So at this time, this vaccine is not for anyone below 16 years of age. Underlying conditions, Celine, I have not heard for any specific underlying conditions. We hear about what about individuals with immunocompromised systems and so on. So what I would say to some of those individuals, it is really important that you have a discussion with your healthcare provider. This is where the healthcare provider comes in again. The same goes for individuals who are pregnant and for individuals who are breastfeeding. At this time, there were some women who became pregnant during the trial. They have not delivered yet, so we didn't know the outcome. And if there are, it's so few that it is really hard to generalize. So for those three groups, actually, I would say, please talk to your healthcare provider, discuss it with him. He knows your history. He knows your underlying effects. He knows if you are in a high-risk group where it's potentially better. Because you know what the vaccine is, and we always need to be clear, this is not no vaccine is 100%. You always weigh the risk with the benefit. Were those all the questions?
The previous positive, so if someone has been positive with COVID, is it a 90-day recommendation that they wait before getting the vaccine?
So there was a lot of discussion about that, and the thought is, and several of us have said, those individuals probably should get kind of at the back of the line, so that they are not the first ones because now they have been infected with COVID-19. But the logistics of that is really still very difficult. So what we are saying is, you had COVID. If you are in isolation, you stay in isolation. If you are in quarantine, you stay in quarantine. But if time has passed after that, you go and you get vaccinated. Those are the recommendations.
Thank you.
Dr. Ford, thank you for the presentation. So when do you think the vaccines would be hitting the general population? So I know there's been talk federally that they said they'd be surprised if it hit in April, but what do you think as far as locally?
Yeah, I do think, so we go through all these different tiers now, 1A, 1B, and then 2. Those are large groups. So I would think for the general population, probably April, end of March, April is a good time frame. Any other questions? Thank you.
Okay. So before I bring you up, Igor, I forgot one piece that I need for the board. I wanted to add this in the consent agenda. It's just you got a piece here. It talks about the transition from Kurt Simon to Lauren Sinsick. I wanted to add this as an emergency, so this happens for the first of the year. So if I could ask for a motion to declare an emergency to add this. And now we need a motion in a second.
Motion to, this is just to.
For this item, yeah, to
Okay.
declare an emergency to add it, because it didn't get in time for the notification.
Okay, motion to approve the emergency.
Declare an emergency.
Declare an emergency. Okay.
Is there a second for that? A second. There's a motion to declare an emergency to add item. Roll call, Sunday.
Yes. Gray?
Yes.
McNally? Yes. Rogers?
Yes.
Espinoza? Yes. Wilson?
Okay, the item to be added is just a resolution appointing Lauren Sinek to replace Kurt Simon as the MAT director on the ex officio piece. So is there a motion and a second for that? You have it in front of you.
So moved.
There's a motion, just a second.
Second.
Roll call.
Me? Yes. Gray?
Yes.
McNally? Yes. Rogers?
Yes.
Espinoza? Yes. Wilson?
All right, thank you all. Appreciate it. Now with that, we'll go to item 6 and the DHS response to COVID-19. Igor.
Good morning, everyone. Thank you for having me. See if I can share my screen very quickly. Okay, I think that's working.
You got in?
Okay, thank you, Commissioner Rogers, other commissioners, for having me this morning to talk about our internal Douglas County Health Department response to COVID-19. If you don't know me, my name's Igor Hadjisulmanovich. I'm an emergency response coordinator for the health department. So one thing I wanted to first talk about was our incident command structure that the health department has adopted for this response. If you're unfamiliar with incident command, it was really a structure that was born out of wildfire fighting in the West. So the federal government decided, how can all these interagencies that work together on responses, local, state, federal levels, communicate with common language and have a common structure so everyone knows who's in charge of what, who's responsible for what activities, and what the reporting structures up the chain of command are. So the health department has adopted that for this response to COVID. You can see within this slide our current structure. I'm mostly going to be talking about our operations section. So again, this is expanded to fit the needs of our response. We've added numerous sections, especially to our operations section. You can also see that our first command and general meeting, where a lot of this decision making happens at the health department, occurred on January 31st. So coming almost up on a year of that date. And again, like I said, mostly objective setting, action items, delineating those to different individuals, and then making sure that we have the resource needs and the staffing support covered so that we can successfully commit to our operations. Something else I wanted to share is the higher Douglas County and City Unified Command. So the first meeting of the City Unified Command structure, again, within that.
Igor, can I say, Sunday, can you make that a single box or move it to the bottom of the top?
Sorry, say that again, sir.
I was talking to Sunday, I'm assuming she's controlling, or you controlling it, make that a single
Yes, drop this.
box to get that, the video out the way.
Does that work? Oh.
No, see that the single line there, the 4 at the top?
Yeah.
That blue one that's lit?
I did it on my screen.
Oh, okay. Sunday may need to do it.
Okay, sorry.
Right here,
Yeah. See that.
Thank you, Sunday.
Okay.
is that enough? It's not moving.
Okay, got it.
Thank you, Sunday. So here you can see our unified command structure. Again, this first meeting was held on March 20th, and that was when we only had 25 cases of COVID within the county. So we've come a long way since then. And again, representation from various city, county agencies, law enforcement, fire EMS, emergency management, public health, and others. And mostly this is to help kind of spread that decision making burden and also provide public health subject matter expertise to these various agencies so that police, fire know how to keep their staff safe and different COVID response type decisions that they might have to make, having good public health input. So you can kind of see where we all fall down within that structure. And of course, Dr. Poor, Carol, Allensworth, Carrie Kernan, Tim, Kelso, Terry Morrow all have positions within this larger structure as well, not just our internal DCHD structure. So now getting down kind of into our internal operations, you can kind of see this is a snapshot of one of our agenda meetings and meeting minutes. So you can see, you know, we have EPI, the information line, health navigation, communications, public information, and our reopening planning committee, logistics and staffing, and then personal protective equipment distribution. And I'll go into each of those with a little more detail. But really the main thing of this slide that I wanted to share is that as the COVID response has progressed, the health department has taken on a number of different items and actions that we didn't really ever think we would be a part of. And we've been able to be flexible and pivot to meet those needs of the community. So I won't get too much into epidemiology. I know you hear about a lot about that every Board of Health meeting, but I really just wanted to highlight on this slide how much Douglas County Health Department has expanded its epidemiological capacity with both, assigning of FTE to contact tracing, hiring 10+ temporary staff solely for contact tracing within the department, and then of course our contract through the state with Professional Research Consultants, PRC, for 200+ contact tracers who are again calling all these positive case individuals each day and doing contact tracing. And then the only other thing is, and Dr. Poor alluded to it, the hundreds of thousands of laboratory reports that have been received and the thousands that are almost analyzed every day. So again, a lot of work behind the scenes that sometimes might not be realized. Our information line, so there's the number down at the bottom for anyone who's unaware of it. They operate 7 days a week, do take some holidays off, but mostly, the information line are there every day, 8:30 to 4 p.m. We started the information line in February once we realized that there were probably going to be a lot of questions from the public, from providers, from agencies on how to navigate the directed health measures, on how to navigate quarantine isolation guidance, and then also with the mask ordinance, handling complaints and getting those to the appropriate people once complaints are made. So again, our information line receives about 100 calls per day. You can see our highest total was 367 calls back in March. And at one point we had over 8 people taking calls. Now, because of technology, we're mostly able to do some of that remotely, and individuals are able to take these calls at home and have all the information that they need with laptops and things like that. Again, the info line has taken 26,700 calls since March, including over 1,500 calls in Spanish. Spanish is our main language, other language that we take calls in. However, we do have the ability through the language line to access other language interpreters if need be. The health navigation program, I think this is a great example of how the health department was able to pivot to the need of the community. Through contact tracing, it was identified early on that many COVID positive individuals had food insecurities, rental mortgage assistance insecurities, weren't able to provide some of those basic needs for their families due to being either in isolation or quarantine. So that's where the health navigation program came out of. So our entire health promotion section and 1.5+ FTEs now work on this full time. You can see that 2,742 individuals and families have been helped with 274 active cases. And really what the health navigators are doing are connecting these COVID positive individuals and their families to resources that already exist in the community. I think one major benefit is a lot of these systems and processes that are already in place can sometimes take week, 2 weeks for individuals to get assistance, either food, rental, mortgage assistance. So sometimes it's helpful with the backing of the health department for us to make some calls on the behalf of these individuals to say, where's their application in the process, why is it not being processed, and what can we do to make sure that these individuals are connected to the resources that they need. Again, you can see navigation area, the number 1 is food access, number 2 is housing, and then number 3 is utilities. Languages spoken by our clients, again, English and Spanish mostly. Communications and public information, I know everybody's very familiar with our PIO, Phil Rooney. Nadia McCracken has also been helping greatly with the communications piece, and Heather from our department as well, with making sure that our website is constantly updated with the newest information. Things like testing sites, vaccination information now, where you can access directed health measures, things like that. So we've been doing daily news releases. We've gotten very familiar at the health department with the bottom right screen. You can see our news release. And again, multiple media contacts for interviews each day for Phil, for Dr. Poor, for our various subject matter experts. And then again, we've really tried to expand our social media presence and tried to get individuals within our community connected to the information that's most important to them. And we do try and ensure that all of our materials are translated into Spanish, and then the other languages that we've been able to identify within our community are spoken most often. Reopening Planning Committee, so another part of our operations section that was expanded to kind of meet the needs of the directed health measures that imparted upon our community. So the Reopening Planning Committee was started based off of the governor's health measure, which started June 1st, 2020. So that mandated that indoor and outdoor locations that hold 500 or more individuals in Douglas County submit a reopening plan to the health department. You can see our template there to the right. Basically, it's just saying how are you going to contact individuals if there is an exposure, what type of disinfection, sanitation are you using, is it EPA approved, and those types of questions. You can see that there's been 80+ plans that we've reviewed and approved, and we've been working with very large organizations such as Henry Dorley Zoo, where that take multiple meetings, multiple calls, multiple considerations to figure out how they can reopen safely to the public. Logistics and staffing, I won't get too much into this other than to just say, Carrie Kernan and Tim Kelso have done a wonderful job ensuring that our operations section has been well-staffed, well-funded with the things that we need. We've been able to expand almost every operational section with staff, which is kind of our biggest need, mostly identified. And you can see some of the other contracts that Carrie and Tim have worked on through the CARES funding. You can see that we've hired over 42 temporary staff and continue to recruit more for our various operations sections. Personal protective equipment distribution. So I would say this is another section of our operations that we never thought that we'd really be a part of. Through our medical countermeasure planning, we always thought we might be distributing vaccine or medical countermeasures, antibiotics, but we never really thought we'd be distributing as much PPE as we have to date. So you can see some of our numbers. We've distributed over 8 million items of personal protective equipment, over 700,000 N95s. 1.2 million isolation gowns, over 4 million gloves, over 1 million surgical masks, over 550,000 cloth masks, to over 1,500 facilities, 700 of those being unique. So we have a lot of repeat facilities. Again, the reason that we started this operation is that the healthcare facilities, especially the smaller ones and the independent physician providers, are unable to get personal protective equipment through their regular supply chains and vendors because of the increased demand worldwide. So the state, through some very good forethought and planning, purchased a large amount of personal protective equipment and then sends it down to the health department to distribute weekly. So every week we distribute to about 30 to 40 facilities. With our max, we were hitting 50 to 60 facilities earlier on in the response. But as supply chains have normalized a little bit, we're starting to see, especially our larger health systems, able to get more PPE. But we have even helped some of our larger health systems get some of this personal protective equipment. And we think, and we've heard from the state, that this might continue to be a problem through 2021. That's it for me this morning. Any questions from the commissioners, I'd be happy to take. Thank you for the opportunity to speak to you all this morning.
Okay. None, Igor. Appreciate it.
Thank you very much.
Thank you. Item B is lead poisoning prevention during COVID. Yes, ma'am. Good morning. So, Igor, while she's setting up, I'm just asking. I saw that. Are you all getting PPE shipments again? I saw that you all got a shipment. What is state provided again?
Yes. Are you talking about PPE in general or cloth masks?
Well, I just saw in here that you all got a shipment in. I thought they had stopped doing that.
No, they have not stopped doing that.
Okay.
We try and work with our healthcare providers to provide data to the state to say they're still in need.
Okay. It's not in as big a volume. They're still getting it. It's like, what was it, 400,000 I read or something like that?
We've distributed 8 million individual pieces.
No, but I mean, what I saw in the report that you just received, like last month, was it? Because before you were getting big pops. Now I thought I just saw like 400,000 in there.
Yeah, I would say probably on average about 400,000
Okay.
pieces a month that we receive at the health department.
Okay. But not that big pop like you were getting before, where it was coming in like, okay.
And it's been mostly some of the smaller facilities recently.
Okay. Okay.
All right, good morning, everyone.
How are you?
Thank you for having me. My name is Nadia McCracken, and I'm the acting supervisor for the lead poisoning prevention program. Today, I'm going to talk to you about what we've been doing since the pandemic began. So first, I really want to go over, it's a little slow. First, I want to go over what program services we currently offer. And these services are all free through a cooperative agreement with the EPA. We provide lead education and outreach to Douglas County residents. We monitor blood lead levels and screenings of children 84 months or younger in Douglas County. We conduct investigations and inspections and education in pre-1978 homes where children 84 months or younger reside, regardless of blood lead levels. We also conduct investigations and education in homes where children are exposed to lead hazards. That is, they have a confirmed venous blood lead level of 5 micrograms per deciliter or above. During those investigations, we provide, the staff will visit the home, conduct a lead education to the family, and also perform a risk assessment to determine what those lead hazards are in the home. We coordinate clinic follow-ups with the family, and we also follow up with the property owner to make sure that the hazards that we do identify in the home are addressed if they're related to lead-based paint. We also provide clearance inspections to owner-occupied homes after all lead work has been completed to address those lead hazards identified. We also have another part of our program which is called the Interior Lead Dust Program, and it basically is a follow-up to the soil remediation that's completed by the city or the EPA. to address high lead levels in the soil. We provide free HEPA vacuums during those visits, as well as education to the residents and dust sampling within the home. We also partnered with Nebraska Methodist College to provide free screenings, free blood lead screenings to children 7 years or younger within the Superfund site. This is done at OPS locations or at outreach activities with parental consent, of course. And also, WIC clinics offer free blood lead screening as well. We currently have 5 staff members on our team. We have 3 full-time lead risk assessors, 1 full-time secretary, and then a full-time acting supervisor, which is me. Our team is very diverse, which I think really helps us. As you can see, there's a little picture of our team over there. We have 2 Hispanic staff members on our team, which has been a tremendous asset for us in reaching the Hispanic community. I would say about 20% of our cases, 25% of our cases do come from the Hispanic community, whether it be them living in older homes or having exposure with imported products. In 2019, we provided services in multiple languages, which included Spanish to the Spanish-speaking population, about 1,000 people we were able to reach, and that was using internal assets, as I mentioned, with our 2 Spanish-speaking staff. We also provided education and other services to Karen, Arabic, Burmese, Nepali, Dinka, and Kanjubal speaking population, and that was just over 200 people. So you can see this kind of shows how diverse our population is that we're serving here in Omaha. It's constantly changing. So since the pandemic began, screening numbers saw a large decline in April, but have gradually picked up since. A similar decrease has been seen nationwide due to low well child visits. It is estimated that nationally there was a 75% decline in blood lead screening from April to July, according to the CDC. Screening at the WIC clinics locally have been put on hold since late March due to there being no in-person visits. So from January to March of this year, we were able to screen 685 children at those WIC clinics. When comparing this to 2019, 3,710 children were screened at WIC locations within Douglas County, so it did make up for a huge chunk last year of children that were screened within the county. Nebraska Methodist College had resumed screening in OPS locations in October and have screened 78 children through November. So for 2020, Nebraska Methodist College screened 194 children at OPS locations in Douglas County. When comparing this to 2019, Nebraska Methodist College screened 1,292 children in Douglas County. So we did see dramatic differences between this year and last year. I mean, OPS locations have been closed for some time this year, and so that's definitely affected screening numbers. What I want to point out here, and I'm not sure if you can see this graph properly, I tried to make it a little visually appealing, but when comparing screening from 2019 to 2020, you can see that we've definitely had a decrease, and you can see that dip that I mentioned in April. 845 children were screened in April, and when you compare that with last year, 1,903 children were screened the previous year. When looking at that blue line for 2020, you can see at the beginning of the year, for the first 3 months, we were projected to kind of go the similar pattern that we did for 2019. But then the dip came, and then it started to gradually increase, and now we're up to about 1,800 since July, which is great, but we're still nowhere near where we were the previous year in 2019. Looking at what we've done in previous years from 2000 to 2020, you can see that, I think you can see that, okay. You can see that screenings have definitely improved throughout the years. We had our highest number of people screened last year with 21,468 children being screened. This year, as of October, we are at 14,931 children. We project that by the end of this year, we'll have about 18,000 children screened, which is lower than we would like to see that number at. But we are trying to get that number to go up. So when looking at elevated blood lead levels as well for this year compared to 2019, you'll see that We do have 91 new cases of confirmed levels of 5 micrograms per deciliter or above, compared to 116 from last year. But again, last year we had more children that were screened, so we saw different things. We do see from the previous graph, however, there's a little blue line that you can see there that screening elevated blood lead levels have definitely declined, and they have been on a decline. Last year we had 181. The year before we had 198. So, and the year before that was 225. So it has been on a steady decline. And so we don't think that because of the screening numbers decline, that we would have seen many elevated levels, but we do have children that are staying home more now than we did in previous years. So what have we been doing to address this? We've actually developed a lot of visual content, and since we aren't able to do outreach events, getting to those schools and so forth, we developed a lot of videos to put on social media. So we developed 5 new videos, but using our staff. So there was videos that addressed lead in soil, lead in imported products, pre-1978 dwellings with old windows, and as well as old paint on porches, and then blood lead screenings as well. The other content created featured both static pieces and animated images, which we found increased engagement online. And the reason that we decided to push so much of a social media campaign is because more people are online. Parents are, a lot of them, millennials. They're utilizing Facebook, they're utilizing Twitter, and so forth. So we found this to be a great platform to interact with them. So from April through November, we were able to reach the following number of people. So 68 Twitter posts, we had engagement from 71,793 individuals. On Facebook, through 24 posts, 27,732. So there was definitely great engagement. We've also been mailing education packets to all families with children that have confirmed elevated blood lead levels, as well as families with children that have confirmed blood lead levels of 3.5 to 4.9. We are hoping that by doing this, we'll be able to intervene when the levels are much lower instead of them going up the previous year, as we've seen in the past. Omaha Public Schools, including Head Start Educare and early learning centers serving children 7 years or younger in our Superfund site, also sent out packets before the start of this school year with education information regarding lead poisoning and the option for parental consent to have children screened for lead through Nebraska Methodist College. We have begun scheduling virtual education sessions with clinics located within the Superfund site to increase screenings, so when those children go in for their well-child visits, they're able to get screenings right there and then, making sure that those providers are asking the questions, has your child been screened, within the last 12 months? So these also include our local FQHCs. In terms of our inspections and investigations, we conduct interviews and provide education via the telephone to parents with children that have elevated blood lead levels, and this is what we've been doing since the pandemic started. Inspections now have a virtual option via FaceTime and WhatsApp. So this was implemented in late June. Prior to that, we did have staff that were involved in the COVID response, but we still were going, we still provided education via the phone, as well as other interventions to make sure that the blood lead levels wouldn't go up. Parents were aware of what was going on. So these, the option for the virtual inspection, it's for EBL investigations and risk assessments, as well as pre-1978 inspections, and those pre-1978 inspections are for where children, they don't have a known blood lead level. The parents just want to know, is this chipping and peeling paint a lead hazard? We work closely with the City of Omaha's lead hazard reduction program and refer all families that qualify so that the lead hazards identified are fixed. Prior to June, when we commenced virtual inspections, we also referred qualifying properties to the city's program. So not only are we going into the homes and identifying the hazards, we're able to connect them to a resource that is able to help them to address those, because it's quite expensive. So how are we doing when compared to other lead programs? During the National Lead Poisoning Prevention Week, which was the last week of October, We participated in a roundtable that was organized by Region 7 EPA office. There were 5 other representatives from different health departments in our region. So there was representative from Kansas City, St. Louis Health Department. There was someone from the EPA Region 7 led office, and then from Iowa as well. And everyone was trying to switch to virtual inspections, utilizing social media more, the telephone, and then mail as well. So what's next for us? We do plan on having a robust marketing campaign starting early next year. We do have to put out bids for that, but we do want to incorporate social media, the television ads. We also want to use bus bench signs and billboards and so forth to make it a bit more rounded so that we are able to reach everyone that we would like to reach. We are also looking to hire more staff. We're currently funded to staff 8 people for the program, so we'll be looking to hire 2 community health workers and 1 community health educator, because currently our lead risk assessors also provide education sessions during the visits as well. So we've recently received grant funding from the Nebraska Department of Health and Human Services to help coordinate lead testing in water for childcare facilities, preschools, and public elementary schools that are eligible. We have already sent out correspondence to those schools and daycare facilities, childcare facilities specifically, to have the requests come in for kits to be sent to them for them to do the sampling. And those kits come from the state lab. And this will be offered through April of 2021. So that's it. Do you have questions?
You are going to ramp it up at the beginning of the year. I was happy to see that, but that's mainly a marketing campaign. Are you going to ramp up testing at the beginning of the year, given the ability with vaccines, et cetera, et cetera?
So in terms of screenings, we are going to reach out to those clinics and so forth because our WIC clinics aren't opened as yet. I think they're closed through the end of this year. Not sure if they're closed until January. But we are planning to utilize our clinics that we do have and our FQHCs to make sure that they are doing screenings within their offices.
Yeah, and on the a follow-up, so would the WIC account for about the 5,000 that because we're down about 5,000 roughly, give or take what we would have probably, because we gain a little bit every year.
Yes, and so most of the 5,000, they're usually at our One World location with clinics, and then also at the Charles Drew location. So by tapping into the FQHCs, those families are already visiting there, making sure that they are getting the lead screenings when they do visit.
And then one other issue we might think about is the children who have opted to do at-home learning, or once we went back, they're at a higher risk because they're in the home longer.
Yes.
So it might kind of put that as, maybe you've already thought of it as a campaign into that.
Yes, we
marketing.
definitely want to. What we're trying to do is make sure that we're bringing awareness to the parents or the guardians at home to say, hey, if you live in a home that was built before 1978, it's more than likely that there is lead present in it. And a lot of our videos that we've created addresses that. And so if they are aware of it, they can call us. We have pre-1978 inspections that we offer. We can do a virtual tour of their house and see if there is any lead-based paint that we can visually detect. And then refer them to sources that may be able to help them.
Yeah, because we're missing 20 to 40 kids probably that we probably would have picked up normally.
Mm-hmm.
Thank you.
Any other questions?
Thank you for your presentation too.
No problem.
Yeah,
Thank
I have a question.
Yes.
So from 2019 to 2020, you had the number of screenings. I assume that there's duplications from year to year. Do you know what that proportion is?
Not off the top of my head, no.
Okay.
I can get back to you with that.
Yeah, I just think it's important to kind of make sure we just have a distinction of, how many of these children are being retested in the next year, as well as what are the new cases, which I think I heard you mention what those
We
new
do
cases
track,
were.
yeah.
I knew that.
We separate the prevalent cases from the new
Right,
cases.
Right, which I saw. I just didn't see if there was that you track which of those cases are duplications from year to year.
So in terms of, that wasn't there. I could provide you with a slide that shows the new cases that we have year to year. we do have that.
Yes, thank you.
Perfect. Any other questions? Thank you very much.
Can I ask you, I don't know how much time you had to think about it, but I'm just figuring it was an issue about, do we still have, now that the pandemic is here, you're doing less home visits, at some point that could come, may change or not. Do we need to take this opportunity to try to address any concerns that were out there lately, like about, the co-enforcement thing when you all come? There was a while where you talking about there's probably some things in city ordinance we need to change. Do we need to try to work on that now while it's not of importance, or is it worth it?
Right now, we haven't really had any issues
I
with.
know, and I don't know if I might be addressing this to you more so.
Oh, it's Dr.
Since you've been in the interim, I'm sure you haven't been baptized with this. You've probably been trying to handle it during COVID, but it's a longer term question, and I'm just looking at you saying, if you want to give some thought to that before it starts going. Okay. I'm
All right,
good.
thank you very much.
Thank you.
Thank you for the presentation.
Okay. Item 4 is the department reports. I've kind of alluded to whatever questions I had in mind floating through. Does anybody else have questions in there for anybody, any of the division chiefs? Okay. With that, then, we do have need for an executive session for personnel and some negotiation matters. So with that, is there a motion to go into executive session for negotiation and personnel? I heard a motion a second. Okay, Sunday?
Yes. Rogers,
Yes.
Callie, Gray.
Yes.
Wilkins. Yes. Espinoza. Yes.
All right, so just for the record, when we return, we won't be taking any action. So if anybody's waiting for anything, we're just going to reconvene and adjourn. So thank you all.